since we've kind of moved naturally into talking about stage 4 metastatic spreading disease, I want to ask you something else about this, and I'll just read something to you. And I teach an online course for people who want to write about medical experiences. And the course is going on now, and the students send in introductions to themselves. And I want to read you one of those very briefly. She said, "The main story I want to tell is about the journey I started on 3 years ago when I was diagnosed with stage 4 breast cancer, incurable cancer at age 34, and 5 days before my wedding." And this, she goes on to say she's in a stage now, 3 years later, living with cancer, being excited when my scans are stable, knowing every day that I will likely not live a long life and be retired and feel old. So my question is, for young women, is anybody looking in particular at younger, I know it's a very small group, but it is just such a wrenching thing to hear about young women who come in with such aggressive disease, stage 4, right off the bat.
You know, I think one thing that's been very interesting is I think that it's really the biology. It's not really age. And I think that it just turns out that young women are much more likely to get very aggressive disease. So it isn't, you can
Why is that? Or it is or it is not? Yeah.
I don't think we know the answer to that, and it may have something to do with the environment in which the tumors grow, and I think that there's a lot of work to be done on that, but in general, you can get a very aggressive tumor at any age. You're just much more likely to get it at a young age versus an older age, and I think one of the things that we're very hopeful about, I think, and when I want to circle this back a little bit to prevention, is that understanding better about what are the factors that drive these tumors, and the more we understand, the more likely we are to come up with things that will help us prevent them. And I think that's one of the reasons why I think some of us are very excited about the opportunity to offer preventive interventions for young women at high risk, and whether it's because they have a strong family history, or are known to have a BRCA mutation, or whether they happen to have atypia at a very young age, that there are things that we can do to prevent them, significantly reduce the chance that they would have a bad cancer. But for women, there's a lot of work to do, and for some of these very bad cancers, like this, where the biology, again, is out of the bag, and this is where screening is not going to help. For these very aggressive cancers, we have to do a better job of understanding what the causes are, and really then take that molecular understanding and get it translated into prevention.
And did you say there was something that can be done for prevention now? Even for younger women?
There are, actually. When we talk about tamoxifen, the people who benefit the most from tamoxifen are young women with atypia, or young women with very dense breasts, who have, people who have a 40% predicted likelihood in their lifetime of having breast cancer. We have level 1 evidence from the STAR trial, from the PO1 trial, that shows that you can reduce the risk of getting breast cancer by maybe 85% in the setting of atypia with tamoxifen.
What's atypia?
So is when the cells themselves, they don't look cancerous, but they look abnormal.
So this is someone who has had some reason to come in for a biopsy already.
Right, so things like low-grade DCS, atypia, those kinds of things, of people in young who could have that, these are the women who would benefit from tamoxifen. And I think the other thing to think about is women who are BRCA1 carriers. These are people at risk for, we know this, that if you are a carrier and you've got the cancer in your family and you have an 85% or 80% chance of getting breast cancer in your lifetime, these are the women who then benefit from having prophylactic mastectomy. It is, doing prophylactic surgery is like, it gives you 8 years per life you're getting, not even transplant, lung transplant or heart. It's probably the most cost-effective or the most life-saving procedure you can do for women. It's really very effective, and there are tools now, or there's techniques now that are very much more cosmetically acceptable.
Okay,
Well,
Well, I was going to move on to another question,
Well,
but
I think here's the sociology of this, and here are the facts. Most women under 40 who get breast cancer, there's high-risk groups that Laura outlined, but most people under 45 who get breast cancer don't belong to those groups. Specific prevention in those populations is going to be hard. The sociology of this among scientists, and I can speak for myself, I work a lot on breast cancer, but also on other tumors, is once you have metastatic disease, it's a bad situation. We're beginning to find targets, but it's still in a scattered way. If I have an idea that would help somebody with Ewing's who's 6 years old, I pursue it aggressively. If I have an idea that would help somebody with prostate cancer who's 80 years old, I pursue it aggressively. There's not that many ideas. We've got to go after them very, very aggressively. What we have found basically, we have two ways of treating metastatic disease more effectively than we've in the past: targeted therapy and potentially immunotherapy. And that's what's going to happen. If you want to know the things that might make a huge difference in the next 3 to 5 years, those are the two modalities. And any idea we have for a particular tumor, we jump on as soon as we have that idea. And I think I can speak for everybody in the room working on this disease, because they're all interested in the other diseases as well.
give us an idea of what you mean, particularly for breast cancer, when you talk about immunotherapy. Are we talking about a vaccine, or? Okay,
well, first of all, I don't want to reject the questioner's question, but as we discussed, you're from Queens and I'm from Brooklyn. And I grew up in a house where I was taught never to be polite and always to butt in.
I think I'm going to lose this one.
If you talk to the radical immunotherapists, immunologists who believe it's the wrong question. They believe immunologic approaches will work against all tumors. If you have a HER2 breast cancer, HER2 is going to work just against the HER2 breast cancer. If you can activate the immune system to reject the tumor, then that ought to work in multiple different diseases. So I will tell you about what I think is the major breakthrough in immunotherapy. Most immunotherapy, I think most people in this room believe, they might not say, most immunotherapy for the last 40 years has not been useful. And most of the experiments have not shown it to be useful. There's now someone named Jim Allison at Sloan Kettering, and his colleagues have found a way to activate the immune system. And when they activate the immune system, particularly in melanoma, where it's been mostly tried, but also other tumors, tumors can disappear. It's remarkable. And this is the first data that tells me that activating the immune system works. And the melanoma trial was the first trial to be approved, where immunotherapy is now approved as extending life. Now, the interesting thing about immunotherapy and targeted therapy can work in 80–90% of the patients, but then the tumor comes back in 8 months, 9 months, 10 months, 15 months. The immunotherapy was working only in 10–15% of the patients, but some of those patients are continuing to live without the disease, as if they were cured. We have it's not long enough follow-up to say that. So I think one of the big things that's happening now, and it's happening in breast cancer, I believe Cliff Hudis is running a study, is where we combine the targeted therapy, which will kill the tumor, make it smaller, release what we call antigens that the immune system responds to, and then activate the immune system. This is, I can tell you, in my lab, it works great in mice, which is, you can wish me a mazel tov. But we're now trying this in people in melanoma and in breast cancer. And I imagine many people around the table will be trying that.
And there's increasing hints from all directions, that some of the markers that can differentiate what we call the so-called triple-negative tumors, that they seem to differentiate along the lines of the markers that look at immune factors, and the idea that there are associated cells that are part of this network that you can interfere with, and that some of the tumors that do the most, who do the worst, actually does look like there's some defect in the immune system. So I think it gives us a lot of hope that this may be a very important way to target therapy, not for every cancer. I don't think it works for every cancer, but I think it does. It is likely to work for certain kinds of cancers, and I think that, again, is very important.
Dr. Sledge, did you want to say something on that?
Well, just simply, first, we already make use of the immune system in breast cancer whenever we give someone Herceptin, trastuzumab, for HER2-positive disease. That's an antibody therapy directed against the cancer. So we're already using the immune system against breast cancer. I think what most of us on the panel think of as immune therapy, however, is something different, which is to say sort of specifically activating aspects of the immune system against the cancer, which is something we haven't been very successful at. There's more excitement now in this area than there's probably been in the last 20 years, primarily as a result of what's come out of the melanoma field, as Neal mentioned, but also because we're finally beginning to get a more nuanced understanding of how the immune system actually works.
Right.
For a long time, we were just stumbling around in the dark when we talked about the immune system. Now we actually have a pretty good sense of how it works, and that hopefully should allow us to apply it to the breast cancer problem in the next few years.